Hello, my name is Antonio Ochoa Ferraro. I am the specialist pharmacist at the Inherited Metabolic Disorder Services in Queen Elizabeth Hospital, Birmingham. We'll be talking about the use of sodium glucose cotransporter 2 inhibitors in treating neutropenia in glycogen storage disorder type 1b, a UK experience. Birmingham is the second largest city in the United Kingdom. We have a very diverse and multicultural population that is one of the youngest in Europe. We had a long history in the Industrial Revolution, but we look forward to the future creating new landmarks like the new Bullring building that you can see at the bottom of the slide. Glycogen storage disorder can be divided in type 1a, caused by glucose 6-phosphatase deficiency, and type 1b, caused by deficiency of glucose 6-phosphate translocase. In glycogen storage disorder type 1b, glucose 6-phosphate cannot be converted into free glucose, but it can be metabolized to lactic acid or incorporated into glycogen, which presents with normal structure in the cytoplasm of hepatocytes and renal and intestinal mucosa cells. Additionally, patients with GSD type 1b present with altered neutrophil function that leads to opportunistic infections by gram-positive bacteria. Hypoglycemia in patients with GSD type 1a is caused by deficiency in the glucose 6-phosphatase that blocks the degradation of glycogen and gluconeogenesis, preventing the production of free glucose molecules and leading to fasting hypoglycemia. In patients with GSD type 1b, glucose 6-phosphate transporter transport glucose 6-phosphate and 1,5-anhydroglucitol 6-phosphate from the cytosol of neutrophils into the endoplasmic reticulum. Accumulation of 1,5-anhydroglucitol 6-phosphate in neutrophil cytosol causes inhibition of glucose phosphorylation by hexokinase. This was very clearly explained by Maria Vega da Cunha and collaborators in her paper, showing the effect of accumulation of 1,5-anhydroglucitol 6-phosphate in the cytosol of neutrophils, leading to inhibition of glycolysis, pentose phosphate pathways, depletion of UDP glucose that causes the neutrophil dysfunction and low survival. In patients with GSD type 1a, undegraded glucose 6-phosphate, galactose, fructose, glycerol are metabolized to lactate, which is used in the brain as an alternative source of energy. Elevated blood lactate levels cause metabolic acidosis. Additionally, increased endogenous production of uric acid and reduced urinary elimination caused by competition with the elevated concentrations of lactase cause hyperuricemia. In these patients with GSD type 1b additionally present with low neutrophil count, impaired phagocytic and platelet functions, and inflammatory bowel disease. Sodium glucose cotransporter 2 inhibitors such as empagliflozin inhibit renal glucose reabsorption at the proximal tube in diabetic and normoglycemic patients, and therefore cause urinary excretion of glucose. Glucosuria decreases renal 1,5-anhydroglucitol reabsorption and lowers serum concentration, as explained by De Fronso and collaborators in this slide. The data presented today was submitted by participating centers at the biannual meeting of the Health Professionals Advisory Panel for Hepatic Glycogen Storage Disorders, organized by the Association for Glycogen Storage Disorder, AGSD. A total of 19 patients were treated in the pediatric centers with SGLT2 inhibitors for neutropenia in GSD type 1b, with doses ranging from 0.09 milligrams per kilogram up to 8 milligrams a day, either on single or split doses on different regimes. The majority of the patients stopped or were planning to stop the use of granulocyte colony stimulating factors, GCSF. And in terms of side effects, one patient presented with torrential urine glucose in the morning, which was resolved with an unevenly split dose of SGLT2 inhibitor. Another patient had 2 occurrences of urinary tract infection that resolved with antibiotic and did not recur afterwards. The adult centers in London, Salford and Birmingham were treating only 6 adult patients at the time of submitting the data. The majority of them were being treated with empagliflozin with doses from 10 milligrams a day up to 25 milligrams a day. I will be giving more details on our patient later, but in all cases GCSF was discontinued or was not required. Monitoring of these patients showed increased neutrophil count with no incidence of hypoglycemia in the adult patients, although it was noted in the pediatric patients, which might reflect a tighter control of these patients. Urine glucose was only noted to be increased in 1 patient in Manchester postprandially and one pediatric patient in London that presented torrentially in the morning. 1,5-anhydroglucitol was measured in the London Adult Centre and the Evelina Pediatric Centre, and the data from the Evelina Centre suggested that plasma 1,5-anhydroglucitol correlated with neutrophil count. Overall, patients show improvement in their skin ulceration and neutropenia, which in some instances resolved. GCSF was stopped in most cases, and additionally it was noted that hemoglobin and stool consistency was improved. Our patient is a 22-year-old male that was diagnosed at 4 months of age after severe hypoglycemia. He had acceptable metabolic control with persistently low neutrophil and platelet count that resulted in recurrent chest infections requiring several hospital admissions at childhood and minimal impact after using GCSF. At age 5, it sustained a prolonged hospital admission for a year that required tracheostomy. And at age 7, it underwent bone marrow transplant with good recovery and excellent metabolic control, after which hospital admissions became less frequent. Despite this, however, several long-term issues persisted, with low neutrophil and recurrent mouth ulcers, chronic diarrhea and abdominal cramps, and hospital admissions. Before starting SGLT2 inhibitors, he only showed an increase in neutrophil count during hospital admissions due to chest infections, but even in those instances, it remained very modest. At the time of starting empagliflozin 10 milligrams every other day, his neutrophil count was 0.2. After a year at empagliflozin 10 milligrams on alternate days, his neutrophil count sustained at the level of 0.6. At that point, it was decided to increase the dose of empagliflozin to 10 milligrams once a day, with another sustained increase in his neutrophil count, reaching levels that had not been seen before, not even during infections. Overall, after treatment with SGLT2 inhibitors, he showed an improved neutrophil count with over 3 to 4 fold increase. His mouth ulcers and skin spots became less frequent. He had no hypoglycemic episode, and his blood glucose was well controlled, ranging between 3.5 and 7, and he had no side effects or urinary tract infection to note. In summary, I would like to say that neutropenia and neutrophil dysfunction in GSD type 1b is linked to 1,5-hydroglycitol 6-phosphate. SGLT2 inhibitors such as empagliflozin decreases 1,5-hydroglycitol and 1,5-hydroglycitol 6-phosphate in neutrophil cytosol. Our experience with 25 patients in the UK, 19 pediatric and 6 adult, show improved neutrophil count and function whilst being well tolerated and safe. I would like to thank the AGSD Hepatic Healthcare Professionals panel for sharing their data and allowing me to present here today, and also the Inherited Metabolic Services at Great Ormond Street Hospital, London, Royal Manchester Children's Hospital, Evelina Hospital, London, Birmingham Children's Hospital, Royal Hospital for Children, Glasgow, Scotland, University College London Hospitals, Salford Royal Hospital, Greater Manchester, and the IMD team at Queen Elizabeth Hospital, Birmingham.